Good afternoon, and welcome to SHM's Practice Management webinar series. This series brings together experts from across the country to cover the most pressing operational topics related to COVID-19. We encourage attendees to submit any questions during the presentation via the questions box on your control panel. For best audio quality, we recommend calling into the webinar by phone and linking to your computer. Instructions for how to do this are visible on this slide. Your microphones have been muted, so please use the chat feature to communicate with us directly if you are experiencing any technical difficulties. This live webinar and other COVID resources have been made freely accessible to the public on our website. Resources such as these are only made possible through member dollars. If you find today's webinar valuable, we kindly ask that you consider joining SHM to ensure continual access to the content you need most. CME credit for this webinar has been made exclusively available to SHM members through our online learning portal. Without further ado, today we welcome Dr. Dia Ross, Chief Medical Officer at Duke Raleigh Hospital, and Dr. Joshua Case, Medical Director for Clinical Operations at Northwell Health, who have teamed up to offer unique insights on how to maintain a safe working environment during COVID-19. Please welcome Dr. Ross and Dr. Case.
Thanks so much. Let's go ahead and get started. So I'd like to start with discussion of something that was in the news over the past few weeks, a significant outbreak of COVID-19 within the walls of a really prestigious institution, the Brigham in Boston. They were thankfully enormously transparent in as they looked back and tried to understand what happened and why it happened within the walls of their hospital, as they did have a number of very good precautions in place. So they looked and asked themselves, essentially did root cause analysis of how did this spread, which in the end was getting a little bit understandably lax about some of the precautions that they had put in place, and looked and asked how they could prevent this from happening again. And a lot of the lessons that they learned we're going to discuss here between us and the experiences of our two institutions, with the hope that you'll be able to take some of what we share and help bolster really your defenses at your home hospitals. So important things to think about as we start this discussion is that there's really no right or wrong answer on some of these strategies. It needs to fit your workplace and the resources that exist within the walls of your workplace. It's also really important that protocols are great, but if people don't do them, they're not going to work. So create whatever is put in place at your institution, make it something workable. And then lastly, not just putting it in place, but monitoring and re-educating to continue to reinforce the strategies you've put in place. Again, if people start to get lax and stop doing them, they stop being effective. So I'll hand this off to Adia.
Thank you. So, as we think about this webinar, many of you have probably already put in place lots of things for workplace safety. And I think one of our goals is just to really, again, reiterate what the key principles are that you need to think about. And then as you go through, as Josh said, there's really no right or wrong answer around the tactics, but you just need to have those tactics. And I think that's the most important. So when we think about the three key strategies related to workplace safety and COVID, you got to have a COVID screening strategy. You've got to have a testing strategy, and you really need to have an infection prevention and universal source control strategy. And so it's all, when we think about this, and as we all know, it's all about risk mitigation and monitoring. And I think what Josh said around the Brigham is really important, because you got to have the strategies, but given where we are and how tired and people are, we have to make sure that our environment is supporting them doing the right thing. Next slide, please. The first thing that we want to kind of talk about is just our COVID screening strategy. And so what I think is important to think about is you really need to have your institutions, you really think about having two strategies, one around patients and visitors and the others around employees and contractors. And they should be related, but separate. You know, and it's really important to think about those and what you're going to do. And each, you know, obviously each institution and the regulatory environment may have specific requirements that you need to adhere to. Josh, I'll let you take the next stab about COVID screening strategy.
Yeah, and so really the screening strategies at many of our institutions are twofold. So it's temperature checks, typically either at entrance or shortly before you report to work. There's a real question as to whether this offers benefits. It's definitely, and whether it does or not, it's definitely not a end-all be-all. So, and I think some of this is projecting a sense that we are being responsible. I think that's part of this, but it's important to, at most places, not just rely on that temperature check. I think we are all aware of that. The next thing that I wanted to discuss was the screening questionnaires. So a lot of these are based off of CDC recommended questions surrounding the most common symptoms, although some of these can be a little bit vague. The local and state regulations that exist and are very different across the country guide sometimes whether there's a presence of these or not, and how and whether that's specific questions to ask or how they are posed. The goal from my perspective is trying to make these meaningful, easy to use, and encouraging a truthful response. We don't really, I don't really have a good insight, and I've not seen great data as to the sensitivity or specificity of some of these questions that are being asked. And the most important thing that, when we'll talk about this later, is what do we do when someone screens positive? What are the policies and procedures that have been put in place to ensure that this screening questionnaire, whatever form it may take at your institution, has some meaning? So I wanted myself to share what we at Northwell Health have recently put in place for all of our clinical staff, anyone really that reports, and anyone that reports into a building at all at this point. Going over, and again, these are the CDC recommended questions with a little bit of modification to try to emphasize for some of our staff members and trying to aim these questions more at COVID and not catching yeses for chronic problems that someone may have. And Adia, so I know you wanted to discuss your health check that you guys do at your institution as well.
Yeah, so at Duke Health, we have instituted an app, and I kind of showed kind of the screens as if you were walking through them from left to right. And it's similar to what Josh has actually with the similar questions from the CDC. And, you know, I will say we've been on a journey around our health checks. You know, we have, depending on the environment within our health system, we initially started with actually employee screeners. And then as time went on, we decided to build an app, and we're still in iterations of that. I know that other institutions have created sign-ons that you have to do to log into your computer as well as an app. And so I think the key is, like, how do you really think about how are you going to create a structure of accountability for your employees, make it accessible, not make it so onerous that they won't do it. And so these are two examples of that. And then you need to think about, you know, what are you going to do if someone doesn't pass the screening? And you obviously have to have the employee occupational health background there to help assist with that. Next slide, please. You know, one of the other things we want to just point out is, you know, just the importance of having a visitor management and COVID screening process. And we kind of talked a little bit about that in the previous slide. So we use the app at Duke Health for the employees in many settings, but we still have a process at the front at our main entrances, patient entrances for the visitor screening. And again, each institution needs to really think about what are you going to do for your visitor restrictions, and how are you going to continue to make sure the work environment is safe, because one of the biggest place of vulnerabilities is having visitors in the hospital, obviously. And although at Duke Health and I think around the country, most of our visitors are being masked, but actually in the patient rooms, there can be variability with that. And Josh, I think you'll talk next about kind of the testing strategy.
Yes, I will. And I just wanted to echo something on the visitor management and COVID screening. I know at the beginning for us, we had restricted any and all visitation, which created its own significant problems. And I think, in some of the places where the virus is surging, that balance of safety in the workplace with the community prevalence of COVID needs to be thought about and taken into account. And that's got to be a challenge as we start to experience, worsening surges across the country.
And I think you're right too about that too. I was just going to say too.
Yeah.
Sorry about that. I was just going to say too. Just thinking about the patient experience and that as well. So. Yeah,
I agree. That was so challenging for our patients and really our physicians when families were not allowed into the hospital. But seeing how critically ill their family members were, being able to speak face to face with our team members became a real challenge, and just that critical communication and that experience for the patient in the bed as well. It was hard. All right, so getting back to testing strategy. So the first thing to discuss is universal patient testing, and I'm not totally clear as to how the penetrance of this across the country. We at Northwell Health were in a uniquely lucky position that we were able to ramp up the amount of testing we were able to do very quickly with the strength of our laboratory services, and have been able to test every single patient that is admitted to our service. So we have, with a reasonable sense of certainty, that we have a PCR test done that was either positive or negative for every single patient that we have had come into our building. Along with that, we also have an enormous capacity to test for antibodies, and are screening every patient admitted into our system with antibodies as well, to further our understanding of the status of that patient, whether they're COVID positive or whether they have had COVID in the past. We're still, I think, trying to figure out how to use some of that antibody data, but it is definitely has turned out in numerous ways to be important and interesting information to guide our treatment and for the treatment of our patients. It's also really important, if you have the ability to understand the differences, particularly in sensitivity of the antigen testing versus both rapid as well as the laboratory-based PCR testing. We use universally PCR testing for our patient screening coming into our health system. The data that we have generated internally, as well as some of the externally available data, really shows that the antigen testing for higher risk populations, the sensitivity is not enough, and we get too many false negative tests in that situation. Staff testing is something that we have thought about. New York State, where all of our hospitals lie, has specific guidance for this at skilled nursing facilities, but interestingly not for acute care hospitals. It's not something that we are doing, but certainly should there be the capacity to do that, could be considered. So really our infection control processes around our staff are focused on those prevention and risk mitigation strategies. Lastly, we do have a process if someone was admitted to the hospital COVID positive to take someone off of isolation after a duration of time after their positive test, as well as resolution of symptoms. This is something that would need to be done in close consultation with your infection control department, with infectious disease. We're very much of the premise that, especially with PPE being more widely available, we're going to be very cautious in taking someone off of isolation. It's unclear for those that remain sick enough to be in the hospital how long is really appropriate that they stop being contagious. That's some information that we don't really know or understand. All right, so Adi, I'll pass it back off to you.
Yeah, I think, one of the things that's important, as you can see in our webinar, is the importance of really having a strategy. But again, tactics without staying vigilant and really making sure that you're reinforcing what you've set in place in your protocols, as we have seen across the nation, is really, you really have to remain vigilant. So I think one of the things that's also really important is, not just testing people upon admission, which we also do as well, and prior to procedures, but how do you make sure that you're reevaluating patients for new symptoms, especially when you have visitors coming into your facility? And then what are you doing to really think about the universal masking? I think most institutions at this point are doing that if they have the PPE available, as well as considering universal eye protection, whether that's face shields or goggles, and really trying to reinforce that with your staff. And I think, as hospitalists, and if you're an administrator, how do you make sure you're rounding and checking in with people and educating them on the fly about why they need to do those things? Because, we have people that are just so incredibly dedicated to the profession, and at times you're just thinking about taking care of patients, and it's easy to forget to take a step back and, as they always say, put your own oxygen mask on first, making sure that, as to protect all patients, that we ourselves are making sure that we're protecting ourselves so that we can be there for people during these surges. And so, just thinking about how when your people are tired, are you reinforcing these important things that we know are important with periodic observations. Next slide, please. And now we'll talk a little bit about infection prevention strategies. And so the next slide. So when we think about what are some of the main things that you want to do when you think about universal source control and also infection prevention. So continuing, we all kind of probably know these as the fundamentals: examining social distancing in workspaces, having a strategy to support mealtime breaks and during dictation, which we think is a really important thing, and having a way for people to actually speak up and having mechanisms for feedback about those. And then limiting in-person gatherings for meeting and conferences. These are things that are really important, and we know that people, are face-to-face, and those interactions are very important. But how do we support our people and staying safe? And many institutions also are not allowing, kind of forbidding any kind of gatherings for holidays and different things like that to just really decrease that risk of transmission. Josh, I'll turn it over to you to kind of talk about physical workspace and some ideas about how to protect yourself.
Yeah, thank you so much. So one of the biggest worries I had at the very beginning of this is I know what all of our offices look like. I think about the clown car where there are 25 people jammed into a Volkswagen, and how do we go from that and try to protect ourselves, protect our teams? And one of the things that we did at the beginning of this is, and we took advantage of staff being asked to go remote, is that some additional space was able to be opened up in our buildings, and we asked to take that over, to give us a little more workspace, to allow people to space out a little bit, to have a little more room. We don't have the benefit of regularly using dictation in our EMR, but the thought of, with speaking, especially if someone doesn't have their mask on, could that increase the risk of giving COVID to one of our team members? These are the things that I was thinking about. It was keeping me up at night. I still worry about it. I'm most worried about one team member being asymptomatic and in one of our cramped offices, infecting a number of other team members and really hurting the ability to care for our patients. So as I continue to work to ensure we have the space that we need and people are able to socially distance, it's just something I think really important to be aware of in all of our in all of our practices is, that safe space that we have, that being our hospitalist office, really making sure that in the area of COVID that's as safe as possible. Adia, so I know that this is a kind of good reminder that Duke put out to your building.
Yeah, and before I say that, I think one of the things we've been trying to do is how do we make sure, because our hospitalists and others have their workrooms and those are usually their space, but we have also been trying to be more flexible, taking away some of the actual computer stations that are there and giving people laptops to kind of facilitate more easier movement and doing work not just in one spot as well. So I think you got to think about and talk to your folks as well about what do they need to feel like they still have a home, but also how are we encouraging people not to just sit and congregate. So it's that balance. But yes, this is a sign that we have and that we designed in our break room just to really make sure that just to remind people, we put them everywhere. The other thing is, we go in the medical staff lounge and we have our infection prevention actually round in our areas and our patient carriers in addition to our medical staff areas. And, we've taken away chairs and tried to, really look at the layout to make sure people feel safe and encourage them to do the behaviors through the layout. So thinking about, in addition to encouraging through education, but how can you use the physical layout to help reinforce the expectations. But again, thinking about signage is really important because that allows people to stop and think a little bit and remind them of the steps that they need to take. And I think, Josh, you're going to talk a little bit about PPE utilization next.
Yeah, so before I do that, I think the, having someone external, this is something that we've not been doing, and I'm going to take from our discussion idea, is having infection control really, rounding on us and giving us input and recommendations and ideas to just continue to try to mitigate that risk is really something great that you guys are doing, and I'll be bringing back to my teams as well.
Oh yeah, when you think about that, just one more thing about that too, I was going to say is we actually started this, I think it was the last 2 weeks, in addition to doing PPE doing hand washing monitoring, we actually have created a dashboard as well that actually looked at universal masking compliance and also the break room. So we're reporting that out every day at our administrative thing. So there is our hand hygiene auditors are walking around, and then we're monitoring the percentage of universal masking and hand hygiene at the same time.
I'm going to shamelessly steal that and bring that to our infection control team.
That's what this is all about, Josh. Exactly. Shamelessly sharing.
That's excellent. Cool. Yeah. So PPE and patient care, and Adia, please feel free to jump in on this one as well, if you have it whenever you want to. So for our COVID patients, I feel like, especially at the beginning, this was very fraught for our teams. As I think we've all gained more experience and comfort in the care of COVID patients, it's as long, is with consistent adherence to PPE practice, it seems quite safe to take care of these patients. We're still doing some things around, trying to limit unnecessary visits into those patient rooms to minimize any unnecessary exposure. But going in and seeing that patient seems to be reasonably safe with appropriate PPE. The challenge is ensuring consistent adherence and not making those mental mistakes, particularly when we're tired and fatigued with this. One of the things we had done during the surge, and I still like to do, and am pushing my team to continue to do, is the PPE buddy, having someone double checking, making sure everything is where it needs to be when you go in, for when you're donning, as well as when you're coming out of the room and doffing your PPE. We are still, reusing our N95s for quite a while. We are lucky at this point to have a supply that, should we want one, we would be able to get one new N95 every day. That's the balance we've been able to make with not using them for too long, but also not having too high of a burn rate where we're at risk of running out. So I think just keeping an eye on that utilization is important. This does seem very safe and has not seemingly increased our staff's risk for contracting COVID from our patients. Non-COVID patients, or patients that are identified as not having COVID or initially thought to be low risk for having COVID, are the ones where I see the biggest risk coming from. Going back to what the Brigham was, I thought they were uniquely transparent about, and thankfully so, in going through their root cause of what happened. So this started from patients that were admitted to the hospital having screened negative for COVID. So we're doing things now so almost nobody, you need a very good reason to use a nebulizer. We're very cautious about placing people on BiPAP. Really, those aerosolizing or any other aerosolizing procedure, we're very cautious about in ensuring that even though they screened negative, that we don't want to have those patients that are missed. We are asking all patients, when they're capable, to wear a mask as well. So not just universal masking of our staff, but universal masking of our patients to further try and reduce that risk. We've talked a lot about universal admission screening, universal precautions. So again, for us, the mask. And so one of the areas where we've had the most slippage and we're pushing back again and fighting the good fight is making sure that our staff in those COVID quote unquote negative patient rooms are wearing their eyewear. Again, one of the areas that the Brigham identified as one of the causes of their outbreak was lax following of that guideline. We at Northwell are just as guilty of having that part slip, and we're working to re-emphasize the importance of that precaution. So, it's a whole menu of items, as we said earlier. There's no one thing, there's no magic bullet. It's looking at all the different options, and we're working to do all we can to reasonably minimize that risk while not interfering meaningfully in the care of the patients that we are tasked to take care of. So I'll pass it back to you, Adia.
Yeah, I think that was a really good explanation of kind of thinking through and being very thoughtful about all the different components and just where the vulnerabilities are. I guess the thing that we've all experienced and really keeps us up at night is just when our employees turn positive, and what exactly are your policies? How do you work with employee occupational health? Have you told people what to expect, and how have you baked in? I mean, many of us have backup systems in place, but really, understanding what's your backup, if you have two providers that go out for testing, because we want to encourage people to be honest. And if we're going to have all these efforts related to screening, then we have to also support them on the back end and have some kind of policies there to support them. So, thinking about your policy for exposure, your access to testing, both, do we want, some organizations, because depending on where you are in the country, and if people do choose to travel for the holidays, are also offering their employees access to testing before they go, just so we kind of know where people are and whether they need it when they come back, and all these things. So, how are you helping your employees know what to expect so that they can not come to work sick, or if they have a little tickle, and not expose people? And then, again, it's like, your staffing plans, thinking about your backup plans and paid sick leave, and how do we want to support people to do the right thing? I don't know, Josh, if you have anything else to add to that part.
Yeah, I mean, so I think, figuring out a mechanism to make sure that that paid sick leave, or ensuring that your staff isn't financially punished for doing the responsible thing and not coming into work. People, even though we're doctors, and I think we're all, we're well reimbursed for the things that we do, this is to leave money on the table sometimes is challenging for people and their own unique financial situations. Finding a way to, whether that's working with administration, your private group, to figure out a way to mitigate that issue, I think is really important. And then also, you know, so interestingly in New York State, so I'm not sure nationally how people are aware of this. So we in New York State are restricted and are expected to quarantine if we go to states with a certain level of COVID in the community. So we've had to put in place certain, you know, policies and procedures for those that needed to travel to those states for family issues or certain things, to make sure that, you know, we're able to get them that test and get them back to work and help make sure that our teams understand those restrictions should they choose to do that travel. Really important to think about with Thanksgiving coming up. All right, so I think, you know, that's the end of our prepared discussion. So two very important things coming up. For those who have been living in a cave, there's an election going on in the next few days. So please go and vote, and please also get your flu shot. And Dia, you know, let's open it up to questions.
Yes, if you have questions, if you can put them in the question box. We do have one. It said, and I'll read it out. I think it's really probably, Josh, you're in the best position to answer this one. We just revamped our convalescence policy at our institutions since we incorporate universal screening. We are using 20 days from symptom onset to move the patient out of the COVID unit, or using the 20-day mark when a patient is coming back to the hospital. What are your thoughts about that?
Yeah, so so what we're doing, I think that's very reasonable, and because of the lack of real data and the lack of us to truly test as to, you know, does a positive PCR with positive antibodies, you know, is that patient technically not contagious or not? It's really hard to know. So your question and the way that you guys lay that out seems very reasonable. So we do something similar. It's 21 days from a positive test if for whatever reason they're still in the hospital. And we know when we did that test, and the respiratory symptoms have essentially resolved for our patients that are still admitted into the hospital. It's very cautious, probably overkill. But this was one area where we did not want to take any chances. And I think it sounds like your institution is leaning the same way, and let's be extra cautious and not take any of those chances. Adia, I'm not sure what your institution has, or if there's a policy yet. Not every institution may have this policy in place.
Yeah, I think it's very similar to yours. I was going to ask you, what is y'all's policy, you know, if you have had COVID, and over what time period are you retesting as well? If you get admitted, you know, if someone said, "Oh, I actually had COVID," you know, X number of weeks ago, and I guess that's maybe why you guys are doing also the antibody testing as well. We don't have that. So.
Yeah. So we universally retest everybody gets tested when they come into the hospital, and so I guess because we're not if someone, when they're admitted to the hospital, screens positive, like they're coming in for a chest pain rule out, or I'm thinking of the ones that I just had, it was a chest pain rule out, and someone had it was like a hip fracture or something, and they screened positive, and so their antibodies came back positive, but out of an abundance of caution, we kept those patients on COVID precautions during their hospital stay because we couldn't be sure. We weren't under control of them through the course of their illness.
Yeah, that makes sense.
Yeah, it's probably overkill, but I'm all in favor of that right now.
I know, agreed. I don't see any more questions in the question box. We'll give people just a couple more seconds if you have one to put in there.
Josh, I have a question. You mentioned the importance of remaining vigilant with reevaluating and screening patients and visitors. As the pandemic sort of enters its 9th, 10th, 11th month with no real signs of ending anytime soon, what are some strategies for maintaining the sort of like collective buy-in from both patients and providers about safety policies? And are you anticipating any fatigue, and how are you planning on meeting those challenges as the pandemic continues on?
Well, I can say that I'm fatigued by it right now, but it's one of those things that I think a lot of what we talked about in, being vigilant. I think a lot of places will see that these strategies, one of the strengths we have is, unfortunately, because we were in this so early in New York, we put these strategies in place very early, and we've seen that they work. And as we've continued to bolster those, again, trying to make it as easy as possible to do the right thing, but also emphasizing and I think monitoring that we are still doing the right thing will be important. Everyone, I think, very naturally, as this goes on month after month, there will be some slippage, but that monitoring and that reminder and an understanding of the importance and why we're doing it, I think will be as helpful as it can be.
Yeah, I was going to say, I just think, we should anticipate that people are tired, whether they say it or not. This has been an extraordinary time to be a provider in this country. And I think thinking, and baking that in and really thinking about how are we re-educating. And the guidelines continue to change. And we were just talking as a group about re-educating on the next, making sure everybody understands the treatment and why we're doing what we're doing for all the different PPE things. And then I think really having a monitoring plan, and we make sure to really share data and try to be as transparent as we can about, any information we have both in the community and internally, and continue to enforce the why of why you need to do these things, right? And I think that's what's important. And then, I always think about, even with my kids, it's like, if you're asking them not to do something, what can they do, right? Like, so we were just having also continue to have conversations about wellness and how we can stay connected during these times. And I think that's also important is, how can we, when we think about the things just as human beings that are important to us and the connection we want to have, what can we do as leaders to still allow them to have that in a different way and encouraging people to do that?
I couldn't agree more. Adia, I have a question for you. So, one of the things we're thinking about is full PPE in any patient that is coding. Just our thinking is, we have these patients where the testing is still in progress and they code, and this is where some of our higher risk exposures have come from. But also a thought that this may be the patient that is, if someone's, especially unexpectedly coding in the hospital, someone who's more likely to have been if they screen negative, either a false negative or was developing it, and we, just didn't time the test right. I was wondering your thoughts on that.
No, I think that's we're examining the same thing right now. They're definitely, we had designed a special airway team initially that was trained in kind of doing COVID airways. And now that people have become more facile at doing that, we have kind of suspended that for the time being, given our current prevalence. But I think thinking about that is always in the back of people's mind. And definitely there's extra PPE and PAPRs on our code carts. But definitely if someone's COVID, we definitely have a strategy for that. But, I think you're right. We need to think about that as well, and how are people, where is that in their differential? And in that moment where, you're stressed out about a code and just wanting to take care of the patient, how do we make sure we're thinking about that and have enough information going in? So I think it's something we're still kind of trying to figure out as well, because trying to figure out what that balance is.
Yeah, and that's something we're in the process of implementing across our health system as well, is putting a limited but present supply of full PPE on the code carts. That's where that kind of that heroism comes in when you hear, you know, that the code gets called out, and naturally every one of us goes sprinting into the room. Is you get caught without your N95 in your pocket, and that's when we've on those occasions been burned. So having that on the cart is something that's great. You guys are doing that. That's something we're in the process of implementing as well. Oh, it looks like there's another question in the queue here.
Okay, I can't see it, so if you can read it out.
Oh, sure. Luke, would you be able to read this? I'm having trouble reading it as well.
For sure. If a provider comes down with COVID, do you use the 10-day from onset of symptoms, 24 without fever, or do you use testing to clear a provider to return to work?
Adia, do you want to take that one?
You know, I want to add, you know, I'm thinking today, I'm like, okay, what are we doing today? Because, you know, I think we're evolving. And so I just want to, you know, I want to point that out and be given some grace with that, because we're trying to do, you know, everybody's trying to do that. But I think right now we're using a symptom-based strategy at this point for returning to work, to try to still, although we have a plethora of tests, to just be efficient in that way, and doing kind of, you know, that way and not retesting.
Yeah, we're also not retesting, and it's kind of that similar day window, presuming that, you know, you're afebrile and the majority of symptoms have improved. Presuming, and this is the other important point, presuming that your clinician who got sick is feeling well enough to come back. That's sometimes an issue we ran into a number of times, was having an understanding that just because they're outside of that window, this can really knock someone on their rear end. And we've had a couple docs where it took a while for them to remotely have the energy to be able to come in and do the work, which, I think we all know, being a hospitalist is not easy work under the best of circumstances. So trying to have that understanding, for some of our docs were not able to come back as quickly as we thought they might be able to, just due to the nature of this disease.
And that's great. We have another question that came in. This one's asking, how are you dealing with crowding on the unit, both during rounds, especially with large rounding teams, and in workrooms?
So yeah, the multidisciplinary rounds was something that we entirely disbanded during COVID, because of just the enormous community prevalence during the big surge, because of the enormous community prevalence. As our prevalence has gone down, you know, we have reinstituted those, understanding that, again, this is not a zero risk thing that we're doing, but the importance to the care of our patients and the throughput of the hospital, with appropriate screening in place and masking and everything, that's we feel that congregation of people for the care of that patient is important enough that that we're doing that right now, while continually monitoring, and we probably would pull back on that at a moment's notice should we see problems as a result of that developing. The workrooms for us, it's again kind of just trying to find as much space as possible in the hospital, and making that available to our teams the best we can, knowing that real estate in any hospital is quite valuable and always in short supply. Again, trying to make that balance the best we can. Adia, I'm not sure how you guys are addressing those particular issues.
Yeah, I mean, you know, I think, you know, it's one of those things that was a little bit of a bummer around not being able to do in-person multi-D rounds, but I think what we've a lot of things have been converted to Zoom, or they've taken a different iteration of them, but we're still trying to get that work done. We also have Epic, and so we've been also toying with how to use secure chat and other things, functions in there to try to get some of that to communicate. And then, I know there's going to be this webinar coming up from SHM around working with trainees in COVID. And so, we really have tried to eliminate huge kind of team roundings. And so, a lot of when I'm on service doing the teaching service, there's a lot of card flipping and, only going to the room and kind of thinking about, a limited amount of things, or maybe going in and examining the patient together. But, that's been something that has been a challenge for us to think about. How do we still, teach learners in this setting, and also protecting people. I think part of that reason we don't have all those big groups as well is to, conserve PPE as well, if there was any issues with that, and still trying to think about learners and being in COVID rooms, but both for their safety and also for PPE conservation. But I think, a lot of things have gone to virtual, and we've survived. It's not, I think we love to just be able to talk to each other face to face, but I think to keep people safe and, as you said, keep the care progressing, that's what has been our main solution, interim solution.
Yeah, we've been using a lot of Microsoft Teams for the vast majority of our meetings across the health system, which has actually been if there's one little shining part of all this, this has rapidly increased the uptake of the virtual experience across our health system, and in some instances may even be increasing collaboration. I have hospitalists in 16 hospitals across the New York Metro. To get people to meet in person on a regular basis is impossible, or more or less impossible. So the fact that I now that Microsoft Teams in our organization has become the go-to way to meet, in some ways, some of that collaboration has actually improved as a result of this.
Yeah, definitely using a lot of Microsoft Teams. So yeah, I think that it's been a different way of doing care, and I think you never want to miss a crisis, and to think about how you can bring people together. And I think that's a good point to say that not all of it has been bad, because I think when you have these multi-site teams, been able to bring people together in a different way.
Yeah.
Great. It looks like we had another question come in here. Our team has traditionally been very social. One team member is planning a Halloween dinner. How do I balance my concerns of losing several team members at once due to these social gatherings with my understanding that people also need social interaction?
That's a good question. I guess I'll take the first crack at this one. So, I guess you can't fully stop people from doing what they're going to do outside of work. I think, knowing about this, trying to make sure that whatever hospital or organizational policies that may be in place are being followed, and trying to make sure that if they could, if they could do something that is socially distanced outside to reduce the risk of there being an issue. You're right to be concerned, and that's a difficult issue. Adia, what are your thoughts there?
I think it's just hard, it's one of those things that it's like, this is what it means to be a part of a community in good and bad times, but it's also, we're human beings, so we need social interactions. And so I think, with Duke's kind of approach is, we started at the university side, people had to sign kind of a credo, faculty did, and about what they were and weren't going to do in addition to the students. And then, that kind of trickles down, and what are the expectations that you've set, and knowing you're right, we can't control people, but also understanding the impact that they have on others. And so just trying to really appeal to that, and that kind of I guess our social good, because you can't really control what other people are doing, but, we've been really trying to lead by example and saying, there aren't going to be any, health system sponsored gatherings that aren't virtual. And so trying to say that, hey, we love that too, but that's the way that we're trying to really encourage people to do the right thing and lead by example. But it's really hard. I mean, I do feel for people, and I think the holidays are going to be different for those, and there's a little bit of loss with that. So I think trying to just call out the elephant in the room a little bit and deal with people's feelings about it, but also appeal to their sense of team and what it means to really be there for each other. And this is one of the ways you can really show you're a good teammate by thinking about your behavior and how it's going to affect others. And so we've been trying to do it from that way, because there's really no way to control people outside of work.
I think you're spot on there.
Well, this discussion has been great, and we really appreciate the thoughtful questions from our participants and the thoughtful answers from our panelists. So thank you, Dr. Ross and Dr. Case, for an informing and engaging webinar. Just as we wrap up here, as we learned today, a safe workplace expands beyond just the physical and is also defined as an environment that fosters well-being across the care team. So the Society of Hospital Medicine's Wellbeing Task Force has developed a check-in guide that is designed to help hospitalists break the culture of silence around burnout and mental health during COVID-19. We're sharing this resource for free with you now in the hopes that it can help your team start honest conversations about well-being during the pandemic and create a space for mutual support to take place. So you can download this check-in guide via the QR code on the slide here, just with your camera on your smartphone, or as a PDF under the Handouts tab on your control panel for the webinar. It is also available for free download on SHM's website under the Practice Management Made tab or the COVID resources page. And we hope that you enjoyed today's presentation and encourage you all to register for the next installment of the Practice Management Webinar Series on Wednesday, November 18th. I am including the registration link in the chat box right now. This webinar is welcoming 3 different leaders from various institutions across the nation, really, and they'll be discussing what their practices have done in light of COVID-19, and also just some best guiding principles for training residents during the pandemic. So we look forward to seeing you on that webinar and also future installments. So with that, thank you again, Dr. Ross and Dr. Case, and we wish you all a wonderful afternoon. Goodbye.